Hey everyone, happy Monday and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course we are here with the Chief Medical Officer of the Centeno-Schultz Clinic in Broomfield, Colorado, Dr. Chris Centeno. Good afternoon.
Good afternoon, Jason.
Welcome everyone. We'll give you a few minutes to join us, get online, invite your friends, invite your family. You know what? Maybe even invite your doctor to join us for our weekly conversations here Mondays on the Centeno-Schultz Facebook page. On Fridays, we are on the Regenx Facebook page. And today we've got a great topic to talk about. It is about your headaches. It is about headaches and what's involved in a diagnostic headache workup. Sometimes it's easy, sometimes it's not. You've got to figure out which structures are causing your headaches. Sometimes doctors can get right to it. Sometimes it's extremely time consuming. Let me kick it over to you, Dr. Centeno. What do we need to know first about headaches? What kind of headaches are we talking about? Those irritating things that are every once in a while, or those chronic debilitating things that just don't seem to go away? How do we think about what headaches are? And then let's get into how we find the cause.
Yeah, so headaches we're talking about today are headaches coming from the upper neck. And these are the kind of headaches that you would see in craniocervical instability patients or in patients that have injured something in their upper neck. Now, many times, for instance, by treating the upper cervical instability, we can get the headaches to go away. Sometimes that doesn't happen, so we've got to look further as to what's causing those headaches. And I think the critical thing I want people to learn today is how complex that can be to diagnose where the headache is coming from so that you can specifically treat that area. It's more than just going to your local neurologist who sticks a needle back here someplace and kind of does an occipital nerve block. It's much, much more complex than that. So I've talked to lots of patients through the years, and I say, what's been done for your headache workup? Well, I'm all done with that. And I find out they just had a single blind injection by a neurologist somewhere in their occipital nerve, and they don't really understand all the parts and pieces that would be needed to figure out exactly where that headache's coming from.
You know, that's such an important part of the conversation here. And, you know, this really is a common theme throughout our shows each week on You've Got the Power. And that's to understand that you've got to advocate for yourself. And that you can't just, you know, think of all doctors like a mechanic. You pull your car in and there's a universal response or a universal testing and universal, diagnosis based on what information or what data is collected. It's extremely varied. So maybe sort of prior to how do they figure out what's going on with my headaches, my question is, how does a person find a doctor willing to do the things you're talking about, willing to think about it perhaps in a more holistic way, perhaps in a deeper way than just, okay, here's the prescription for the drug, here's the referral to a surgeon, but is willing to sort of play Sherlock Holmes and take the time and energy to investigate what perhaps more natural, more holistic, more conservative approaches there are than just drugs and surgery. How do people find that kind of doctor? Because most people, I don't think, feel very confident to sort of co-manage themselves or even advocate for themselves with their doctors. How do they go about doing that?
Yeah, Jason, it's not so easy to do that. What we see, and this just gives you some idea of how hard it may be out there, is that we see less than a handful of patients a year that have had a substantial headache workup. So out of 100 patients, we might see one or two or three who have had that kind of headache workup to see where their headaches are coming from. Obviously, that means there's 96, 7, 8, 9 out of 100 who have never had it done. So I'm assuming the reason is that it takes some time, it takes some thinking. It can sometimes take a really good physical exam to know what you're going to lead off with and what's the most likely thing to give results. And it takes, in the end, some critical thinking. And I'll talk about one particular patient that we had recently, and a little bit later, once we kind of flesh this out, uh, to just show you how difficult it was in that one particular CCI patient.
Well, let's get into the process here. We got a lot of people watching. Questions are starting to come in. We'll get to your questions in just a moment. So let's sort of lay out this, unpack it a little bit. This is for people that have chronic headaches. This is not just the sporadic. I felt something, it went away, I'm good. But as you said, oftentimes related to CCI, craniocervical instability. Let's maybe first lay out how you think about what you're looking for. And hopefully, if people are watching, whether it's live or in the future, they can then maybe jot down some notes of if they are going to go to a local doctor, what should they be, looking for, asking, how should they hope their doctor is thinking about analyzing and looking for the cause of their headaches?
Yeah, that's a good thing to talk about. So let's break it into two primary areas that are the biggest culprits, either upper neck joints or upper neck nerves. And when it comes to upper neck joints, the C2-3 joint is one that you can commonly get injected most places in the United States that are medium to large size cities. So the C2-3 joint is a pretty common cause of headaches. Then we would go above that and be talking about the C1-2 and C0-C1 joint. And as I've talked about before on this show, that's really hard to find a doctor who has enough experience injecting those two joints to really make a go of it. So that's probably something that you're going to have to travel to get done. And then if we go on the nerve side, we've got lots and lots of nerves that could potentially be causing these issues. Everything from the greater occipital nerve to the lesser occipital nerve to the third occipital nerve to the temporauricular nerve to the transverse cervical nerve. So, and that's not even an exhaustive list. That's just most of the common ones. So that gives you some idea of what you're looking for. Now in the nerves, greater and lesser occipital nerve injections can be done by lots of people out there. And if you get those, you'll want to make sure that the back of your head goes numb to make sure that they actually blocked that nerve. Third occipital nerve can be blocked frequently by a pain management spine expert under x-ray guidance at the lateral part of the C2-3 joint. And then temporauricular nerve, harder to get done. Some dentists will do it. And then the transverse cervical nerve, highly specialized block, unlikely that you're going to find that locally. So that gives you some idea of some of the things to think about.
For those that might be new to the conversation, new to this, or maybe experiencing a debilitating headache at the moment and can't think very straight at the moment, exactly. Let's break down, when you say nerve block, let's dig deep. What exactly does that mean?
Yeah, so that's a good question. Nerve block simply means that we have injected a numbing medicine around the nerve, and the nerve goes to sleep and numbs out. And so if that nerve is causing your headache should go away. So it's a pretty simple concept. It's also called a diagnostic block. You can do that with the upper neck joints. You can do that with all these nerves. You're numbing something out to see if that thing is what's causing the pain, because obviously after it's numbed out, it's not transmitting any more pain.
It's a way of differentially diagnosing the specific irritant to what's causing the symptom. Let me ask this from another way so that hopefully viewers can really learn something from this. You mentioned 96% are going to, I'll call it, good but yet regular doctors, for I guess lack of a better way of explaining it. What would most of them expect to have as an experience, and what's the contrast with what they should hope for in an experience? Just in detail, what's happening to most people when they go, "Hey doc, these headaches just won't go away. What should we do about it?"
Yeah, the two most common things we see is they'll go to a neurologist for the headaches. The neurologist will do Botox injections, which may or may not help. but that's not necessarily a very good thing to do with a CCI patient. And or the neurologist will do some simple occipital nerve blocks back here. Or on the other hand, they're in the interventional spine pathway, and they go see an interventional spine physician who will do a diagnostic medial branch block to see if that joint, and this would only be C2-3 because you can't do that higher than that, is causing the pain. And if so, they get radiofrequency ablation, which is where we burn the nerve away with a little probe. Again, not a great thing to do with a CCI patient. So those are the two most common things we tend to see. And as you can see, they're on two different tracks. So if you're on this track, you get this stuff. If you're on that track, you get that stuff.
And that just comes from those types of doctors that have been trained to look at and treat the body. So
correct. It's just the way they've been doing it forever, or they were taught by their mentors. So all of these things on this list are not going to get covered. Now, listen, the good news is those are two relatively common causes of headache pain. So it's not out of the ordinary that you might get traction there. In which case, that's good information to give us as we go to treat that area. But if you don't get traction there, that's generally where a lot of our patients live. Then obviously we've got to go in and check all of those boxes like we just discussed.
Let's complete the thought and then get to questions. So somebody goes to their doctor checks things out, based on their philosophy and training of, how they've been taught to look at the body. We tried this, we tried that, it's not working. At that point, what do you suggest? Do you suggest that a person suggests to that doctor, hey, what about this list of other nerves I've learned about? Can you check those also? Or should that be a red flag of sorts to go, wait, this doctor's not really looking to invest the time and energy to go deeper. I should therefore use that as a sign to find a different type of or a different doctor who is willing to go deeper. How should somebody navigate that experience?
Yeah, so we're talking about that first layer up there, right? And in that first layer, you get those two injections we talked about. Neither of them really do it for you, or if you're on this track, it doesn't work. You're in that track, it doesn't work. Then you've got to see if that doctor is willing to go deeper. So then I think a real reasonable question for that doctor is, can you give me the list of things that you can rule out that cause headache? And obviously on that list should be the upper cervical facets, 0, 1, 1, 2, 2, 3. Also on the list are all of those nerves I talked about. So that's going to be greater occipital nerve, lesser occipital nerve, third occipital nerve, temporoauricular nerve, transverse cervical nerve. At the very least, there's also a sphenopalatine ganglion that you can reach up the nose. So there's other things as well, but they just suffice it to say this list should be pretty long. At least a half dozen to a dozen different things that have to be crossed off that list to make sure that this headache isn't coming from the neck. Because realize it's also possible that the headache is just coming from the irritation of the covering of the brain, which can happen in CCI patients as well. So you want to make sure that you've crossed off that list of half a dozen to a dozen things before that's concluded, because if you have that type of headache, we have to treat the CCI. And if we treat the CCI and that doesn't go away, then someone may need to open up a hole in the back of your skull just to see if it helps. And obviously that's not a good thing to do to someone without knowing for sure that that's going to relieve their headaches.
As you said in the description, this can get awfully complex. If you've got questions, I'm going to take them in just a moment. My last question for the moment, though, is let's add the layer of time and money, let alone insurance, into this conversation. Does insurance cover all of these diagnostic tests? Is it something a doctor is going to say, well, we can do that, but you're going to have to pay for it? Or how does the reimbursement, financial cost, and time, play into the decisions and the right decisions that people should be making?
Yeah, so the good news is if we're just talking about the concept doing the diagnostic block, which is a numbing injection, then all of the things I've talked about are covered by the vast majority of insurance plans. So I think getting to that answer should be covered. Then we got to get to if the headaches don't go away, but we know where they're coming from, then the orthobiologic treatments may or may not be covered, usually not. But at least figuring out where to put that stuff should be covered.
And in the event that they do find something, they want to do something in the traditional sense of things, what's the most common treatment? And does it work? Does it last? Is it worth going down that road compared to others?
Yeah, so for example, let's say we find out it's a C0, C1 facet joint in your neck. That's the joint between the skull and the atlas. If that's the case, then you can treat that joint. You can use high dose platelet-rich plasma. You can use bone marrow concentrate to try to get some healing in the joint. So yes, it's definitely a good idea to find out where these things come from. Realize that a lot of our patients, once we treat CCI, the headaches go away anyway. So we're talking about this smaller percentage of people with chronic headaches that just aren't getting better, no matter what anyone does.
Outstanding. And the traditional medical approach, I appreciate what you said here, which is using orthobiologics helps the body heal. If they stay in the traditional model, what is it that a traditional medical doctor is going to do in order to address these headaches? And how is it different than a healing approach when oftentimes they're, medicating the pain away, or as you said, burning the nerve? If you burn a nerve, it's not going to work. Of course, you're not going to feel anything, but that doesn't mean you've actually helped your body very much in the long term. Help us understand the differences in the long-term consequences of those different approaches.
Yeah, obviously, if we're just going to block something and numb it up or put a little bit of anti-inflammatory around it, that's usually not a long-term fix. We either have to find out why the area is still being painful, and that can be physical therapy, chiropractic, etc., to take loads off of that area. Or if the area has been damaged, we have to inject something that can ramp up healing and repair. Obviously, that could then get to a longer term solution.
Outstanding. All right, that's enough for Curious Jason. Let's go to everybody else's questions over here. We got Dan Wren, regular viewer. Hey, Dan, thanks for watching. And here's Dan's question. He says, "Hi, Dr. Centeno. I'm 2 months out from my second PICL, and my neck feels looser than ever before. Parentheses, looser than before PICL number one. Several other patients in the Facebook group have also experienced this looseness 2 to 3 months after the PICL, long after the inflammation from the procedure has gone down. How common is this in your experience, and what do you think might be causing it? Is the new collagen initially softer than normal collagen, or does the reorganization of collagen fibers create temporary ligament laxity or something else? Thanks."
Yeah, so I think I addressed this a couple weeks ago on the blog, but I'll say it again. At the end of the day, there's a couple of different phases of healing. The first phase of healing would be swelling within the ligament. For a lot of patients, that feels good because things are artificially stable and tight. Then as that goes away, it's going to feel looser or maybe go back to what it was. And then as new collagen gets laid down, as you get into months 3 and 4, really closer to month 4, then things will tighten down again. Now you have to realize, and I've probably said this 100, maybe 200 times in the show, but I want to reiterate it again because I think it's absolutely critically important that there's 2 components to stability. One is ligament, the other is strength. So if you're feeling like there's a need for more stability, you've got to get into the strengthening portion of this type of program, because half of your ability to stabilize the upper neck is going to come from the muscle strength that has been substantially lost. Most CCI patients have lost about 80 to 90% of that muscle size. So think about that for a second. If you were to walk around in a brace for 6 months, and let's say I put your knee in a cast, and I take the cast off after 6 months, and your quadricep thigh muscle has shriveled up to only 20% of what it was before the cast went on, you're not going to be able to walk. I mean, it's going to be years before that quadriceps muscle is anything back close to what it was after that cast went on, or before that cast went on. So at the end of the day, there's that other component that you've got to be working on. And sometimes that's not so easy. That's like threading a needle between getting some additional strength, but not pissing the area off too bad. So that's the other thing I think needs to be looked at, is getting that additional strength and going through those exercises we have, or working with a local therapist who can help with that.
It's a super important point of the conversation for everybody listening. The hope most of us have is, I go to the doctor does the work, I pay, or the insurance company pays, and the work is done, I can move on and get back to feeling good and doing what I do. But the participation, the engagement, the enrollment in sort of doing our part to help the consequences of the damage, of the time it's taken in many cases, is an essential part of making sure you get maximum healing improvement, not just symptomatic relief or temporary symptomatic relief. So I hope everybody's sort of hearing that, it's almost a baton handoff. The ligaments are tighter so that you can now do those exercises and get the other half of the equation in order to be able to experience maximum full healing. So great point to make, and we probably will not stop repeating that a few more 100 times over the months to come. Here we go. This was submitted in advance by Madeline Sheridan, who says, just heard about this Facebook Live. I've been to 3 different supposed expert neurologists, and no one has been able to tell me what is causing these horrific headaches. Where are you located? Doc, do you want to mention where you're located and how somebody would get in touch with you if they'd rather have you or someone there do their workup?
Yeah, so Centeno-Schultz Clinic is in Brimfield, Colorado, which is outside of Denver, between Denver and Boulder. I think, again, just hearing the word neurologist, the problem with neurology is that outside of that simple nerve block in the back of the head that we talked about, greater or lesser occipital nerve block, their solution to headaches these days is either medications or Botox. That's it. That's all you got. So on that long list of things we talked about, that's only striking off 2 of the dozen things that can cause headache. And I think this is a good time to probably go through how complex this can be. I saw a patient this last week, and we had gone through various things before. So we did a block of 0-1 facet joint, 1-2 facet joint, 2-3 facet joint. That didn't help. Then we did a block of the greater and lesser occipital nerves. That didn't help. Then the third occipital nerve at the back of the head. That didn't help. Finally, when we went in to do the third occipital nerve at the lateral C2-3 joint on X-ray guidance, it was clear that there was a transverse process at C3, which is a little bit abnormal. You normally don't see that there this big. And what that had likely done is to push the nerve up into a place where it was getting irritated by a damaged intertransverse ligament. So by treating at that spot, we were able to eventually get rid of the headaches for the first time in years. But that's not something that you could even do following a protocol written in a book, because you had to think to yourself, okay, she's got a transverse process here. Most people don't have one like this. Where would the nerve end up if that transverse process were to grow out like that? It's going to end up above, sitting on top of that transverse process. What else is on that transverse process right there? The intertransverse ligament. That could have been injured when she got her CCI. So we've got to treat the intersection of those 2 spots. So that took the better part of a week, 3 different visits, and a lot of thinking and introspection as to what could cause her headache based on her unique anatomy. And that's how difficult this stuff can sometimes get.
Do you find that many, I'll say traditional doctors, whether neurologists or others, they find that by offering the treatment itself, that is as good, if not better, and I mean in terms of both effectiveness and reimbursement, than doing all of these tests? Is there a differential or a motivation to approach it from that point? Like, let's try all these different steroids or other types of Botox injections. Do they pay better than testing, or is there a motivation that they just want to get that route, or do they just not have that much experience helping these types of symptoms? And even with the best of intentions, they just don't have the right resources to be able to really help fix these problems.
Yeah, I think a lot of it is a little bit of both. On the neurology side, Botox pays very well. So there's been a movement towards doing Botox injections based on very high reimbursement for what it is you're doing, i.e. reimbursement per unit time is high. Then on the other side, a neurologist is really not equipped to diagnose headaches coming from the neck. They don't have the skill set with regard to x-ray guided procedures or even ultrasound guided procedures to really figure that stuff out. So they're really the wrong provider. Now, it might be a great provider to go to if all you have is migraine headaches and you take some migraine medications and boom, they're gone. That's a different story. But we're talking about the kind of headaches here that are coming from your upper neck, and we're talking about the kind of headaches here that aren't going to be helped by migraine medications at all, or at best minimally. Another big potential problem that we see is pediatric patients. And I'm not talking about little kids. I'm talking about teenagers who end up getting pushed to children's hospitals. And if you think it's bad with regard to neurologists and interventional pain guys, it's 3 times as bad as you're at your average children's hospital treating a teenager who's injured their neck with chronic headaches. Regrettably, there are even fewer resources there. And sadly, many of those kids get placed on low-dose naltrexone or other types of medications to try to help their headaches, which then creates a whole new set of problems we have to work through.
That's 100% the issue. And even if you found a medication that helps relieve the symptoms, as a chiropractor, and my philosophy and training always says, well, let's try to find the cause, because what are you going to take the drugs forever? And as you implied, they call them side effects. I'll just call them real effects of, taking medications, especially over time. So though that may be a temporary win of sorts, wow, I feel some relief. I'm not sure it really solves the long-term problem necessarily, but that's, again, a way of thinking that the absence of symptoms, it does not equate to healing, repairing, curing, or fixing the actual cause of the actual symptom itself. So important is, again, if you want the power, you've got to know what your goal is. And most people think their goal is to just get out of pain. Our suggestion is that your goal is actually to find and correct the cause of the symptom. And those are 2 different courses, oftentimes with 2 different solutions. But unless you know that, you don't know what you're looking for. And if you've watched too many drug commercials, you're probably just looking for the fast relief. So let's keep going with questions. We got Maria Melisova. She says, hi, Dr. Centeno. Do you know the mechanism behind benzos and why they help the neck feel more stable and symptoms disappear? This is just what we're talking about. Shouldn't the muscle relaxing component not worsen the instability? One has to be extremely careful with them because of the possible addiction. But I am wondering how this does work in CCI. And she says, thanks, with some prayers.
Yeah, so I think if benzodiazepines, and just to make sure that people know what we're talking about Valium-like drugs. Xanax is a benzodiazepine, for example. That's a common one that we see out there. And if benzodiazepines make your neck feel better, then the CCI is probably not the driving component. The driving component is probably other things leading to the muscles being tight. So while there may be some CCI, it's probably not the driving component, because most people with quite a bit of instability don't do better with benzodiazepines. It actually makes them much, much worse. But there are a number of people with more mild CCI who do seem to get better with benzodiazepines. And yes, you've got to be careful because all of those drugs are quite addictive, and getting off of them becomes a problem. I just saw a woman who was taking low dose Valium, 2.5 milligrams, which is pretty low dose every day, a couple times a day. But even with that, getting her to sleep during a procedure on the anesthesia side was a nightmare. I had given her, by the time we were done, the equivalent of about 8 Percocets and about 5 10-milligram Valiums IV, and she was still talking to us. So realize that all of those drugs, including THC products and CBD products, dramatically increase the amount of medication it takes to get you asleep for a procedure, which then has its own set of issues.
Always important to try to find and correct the cause when you can. Elizabeth Escardo says, Dr. Centeno, thank you for my diagnostic testing and procedures last week. Also prayers. I'm feeling great. You are absolutely brilliant. Thank you. Any comments you want to share?
Yeah, no, just that Elizabeth had a complex workup for headaches, and there's a good example of how long it can take sometimes to get to that right answer, just because there's so much involved and everyone's anatomy is just a little bit different.
Excellent. Here we go. This is submitted in advance by Harry Winston, who asks, what kind of doctor would you go to? I'm in the UK, so national health and getting referred to a specialist isn't easy.
Yeah, I mean, the good news is Regenexx has some UK providers who we've vetted. So that's where I'd probably go for a headache workup. I think they can do many of the things that I'm talking about here today. So I think that would be a good place to start. Now, if you wanted to stay inside the NHS, then you're probably going to want to find an experienced spine interventionalist that does a lot of cervical X-ray guided and ultrasound guided procedures. Now, I wish I knew a good way to find that out within the NHS, but I don't. So that's why you might want to go to the Regenexx providers we have in London and just outside of London there, because they've been vetted to know how to do a lot of what I'm talking about here.
Outstanding. This is from Chris Miskfit, I believe. Chris says, could you tell us about the 2 cases you know of improving CRPS using stem cells for an operated ankle and in a spinal cord injury? There are some clinics claiming they can treat CRPS with stem cell infusions and only find publications to be working on mice, not in human, and none from those clinics. What is your guess?
Yeah, listen, if anyone wants to tell you that they're going to treat your CRPS by injecting something into your vein, I would run fast away from that clinic. That's total BS. What I mean by that is that many of the problems with nerves, just like other structures, would be that they would have a poor blood supply. And if I inject something here, it's first going to go through a pulmonary first pass. So if it has stem cells, and believe me, the stuff they're offering to inject in your veins does not have any stem cells. That's total fiction. But let's say it did, they would get 97% of those would get taken out in your lungs. And then even fewer obviously would end up in an avascular or poorly vascular area around a nerve injury, which frequently has scarring. So to try to treat CRPS, you would need to treat that local nerve injury if it's type 2. And I'm assuming that's what you've got. It sounds like it's a type 2. And that requires ultrasound guidance and direct injection around the nerve. You don't really need stem cells to do that. You can use platelet growth factors, but it is a high skill level procedure. And it's not something that can be done by a nurse practitioner or a physician's assistant in a chiropractor's office or the orthopedic surgeon down the street. It would need to be done by someone who has done a lot of peripheral nerve hydrodissection work. And those people are out there. They're just few and far between.
Thank you for that response. Pia Homeler She says, thank you for all this information. Have you thought about doing a blog post where the nerves are shown and named? I just realized the nerve on the side of the neck is an issue for me. Thank you.
Yeah, I did. I was going to do it this morning, but I had gotten behind in some of my daily medical director work that I had to catch up on, so I didn't get to blog this morning. But that'll probably be tomorrow's blog unless something else comes up that's interesting. But I will do it sometime this week for sure, because I think that's an important one to do. Now, I had previously done one like this. I'll have to look that one up, but probably time to do it again, because I find sometimes on the blog, if I haven't done something in a couple years, it's good to do it a second time for another take on how to approach that and how to get patients to really bite in and understand, because that's not an easy thing to do when it comes to complex, crazy nerves that half the doctors haven't even heard of, let alone a patient.
Brings me back to school days. Thank you for that recommendation, Pia, and everybody will benefit from your question. Okay, stay with me on this one. This is from Stephanie Adele. My neck has a slight tilt to the right. Even after an AO adjustment, which will make my head more straight, it still feels like there's an empty space not holding my neck evenly upright. It almost feels like there is a muscle that is not engaged or missing. I did experience a very strange nerve dying feeling right when the head tilt started as a result of a physical therapy injury. My question is, could I possibly experience nerve damage, which is now causing a muscle not to be engaged? If yes, is there any test to find out if this nerve is still alive and functioning? It is on my right side of my neck and feels like the front of my deep cervical muscle area. Thanks.
Yeah, so muscles going offline in the upper neck is extremely common. In fact, when we look at MRIs of patients that have chronic headaches after any kind of traumatic injury, we will see not only, well, we can't really see on an MRI if the muscle is offline, but we will see severe muscle atrophy where the muscles shrink up because they're not doing their job. So it's a very common issue. Now, what causes it? It can be caused by injury to the upper neck joints. It can be caused by an injury to the nerve that goes to the muscle, but I think that's less common. It can be caused by irritation of the associated upper neck nerve, so the body is shutting down the muscle to reduce the nerve irritation. It can be caused by damaged ligaments, which then cause too much motion, and then all the things we talked about, and then the muscles shut down. So lots of different things can cause it, and seeing an upper cervical specialist like NUCA or AO is a good idea to see if they can help you. And then if they can't help you, someone needs to take a closer look at it that treats the upper neck all day, every day, so that they can have a good sense of what's happening, why that's happening. Realize your head tilts because of proprioception, and the muscles and the joints provide that position sense. So your head tends to tilt because that's the bad information coming in from the upper neck joints and muscles that cause that to happen.
Also important to remind everybody that taking care of your neck, taking care of your spine proactively is a really good idea. Yes, accidents and injuries happen, of course they do, but it's the day-to-day sort of maintenance, wellness, and positioning that many of us can pay better attention to in order to be able to help us strengthen and reduce our risk of these types of things happening. Last question I got for here, unless any more come in, is from Mandy Jacobson, who asks, what's wrong with low-dose naltrexone in this scenario?
Two big problems. One problem is obviously it's a crutch. And what I mean by a crutch is that, once the medical care system hears that that helps your problem, then they're done trying to figure out what is causing your problem. So while it's certainly good to have something you can use to help the pain, and low-dose naltrexone is better than high-dose narcotics, it's also, the problem is it also stops all attempts at trying to figure out why that pain is there. So you're left with the medication you've got to take for the rest of your life. Then the second part that's the biggest issue that we see is that it dramatically ups anesthesia requirements. So if we get you in to do procedures, if you would have taken this much without the low dose naltrexone, you now take this much to get to sleep. So it dramatically increases the risk of any procedure, including injection, surgery, et cetera, that requires anesthesia. So that's what we see. So again, the biggest issue is not that it doesn't work in some patients, it does. And not that it's not better than taking high dose opioids, it is, but that once that works, the work of the medical profession is done in figuring out why it is you have a headache. And that's obviously not a great place to be if you're a patient, because who wants to take any medication for the rest of their life? We all just know intrinsically that's not a good idea, right? Hoping we do.
Well, let's clarify that and make sure people do know the difference. One of the ways I learned early on is that again, we have learned in our system that the goal is to get rid of the symptom, the pain, the end goal, the end stage. And you could think of that metaphorically like a fire alarm. A fire alarm, if it was going off every day, all day, would be absolutely super annoying for everybody in ear distance. And you would think that the goal would be to turn off the fire alarm. But if the fire alarm's going off, it's probably going off because somewhere there's a fire or some smoke that has set the fire alarm off. And the question you'd have to ask yourself is, which is it that you would want to, would you think would be a smarter approach? Let's just cut the wires to the alarm system so that it's not as loud and annoying and irritating? Or do you want to do the investigating to find out, why did the fire alarm get tripped in the first place? What's causing the symptom? What's causing the body's warning system? That's what symptoms are. What's causing that to be so loud, to be so irritating? It's in fact doing the job it's in fact supposed to be doing, which is to say, hey, stop, pause. We say that the word pain means to pay attention inside now. And that's not, what do I have to buy, take, and do to suppress the noise so I can get back, knowing that the damage from the suppression will extend the problem out even longer over time. That's the difference between just simply temporarily addressing symptoms, I'll say at all costs. Many of these opioids actually, the cure is worse than the disease when you become an addict and have all kinds of other problems as a result of it. So that's the thinking behind as an advocate for yourself. Again, the name of the show is You've Got the Power. And the reason you've got the power is because you've got the knowledge to understand how to navigate the difference between, sure, I'll live on your drug forever. I feel spaced out and wonderful. The pain's gone. And we'll see what happens over time, versus how do we find and correct and then heal the actual cause of the problem through different type of orthobiologics and regenerative medicine type approaches. Does that sound right to you? Am I misstating anything there that you want to clarify, or what else do people need to know about that, Doc?
Yeah, again, I think my sense is that at the end of the day, it's good to find a medication that can help, but then you need to say, okay, that's the medication that helps. Now we have to go on the rest of the journey to figure out what the cause is. And I think that's the biggest concern I see with low dose naltrexone, especially in pediatric hospitals these days. Teenagers are getting put on this stuff left and right, and then no one at that juncture is interested in talking about what's causing the headache. The headache's solved, lady. Why are you coming back? Just keep taking the low dose naltrexone.
We cut the wires to the alarm. What do you mean the building's still burning?
Yeah, exactly.
Mandy Jacobson follows up with a thank you. You are welcome, Mandy. Doc, that's all the questions I've got for right now.
Okay.
So our topic for today, we had a lot of people joining us after we started, so let me reiterate. We're asking the question today, what's involved in a diagnostic headache workup? And what do you need to figure out in order to know what's causing your headache, whether it's a simple, we found it, or whether you need to advocate for yourself and really dig deep into what the possible other causes are. Doc, let's summarize for today, please.
Yeah, just at the end of the day, headache workups can be simple, i.e., you get it on the first try and you're like, aha, it's the right 0-1 facet joint, that's what we need to treat, or they can be complex and time consuming. Obviously, it's great when they're simple, but if you're in that situation where someone's tried to get rid of your headache through an injection and it didn't happen, you probably are going to need someone who's going to go through that list of a half dozen to dozen different causes, each one requiring a different injection to see what your headache is being caused by, because that's a critical part to understanding how to get rid of it. So at the end of the day, just wanted to give a shout out to the complexity here. And it's wonderful when things are simple. But the problem these days is when things get tough, the medical care system tends to just throw up its hands and say, I don't know, not my problem.
We don't have a drug for that, so you're on your own. That seems to be the case. So listen, take your power, learn as much as you possibly can. If you have not already, make sure that you go to regenix.com and you sign up for Dr. Centeno's blog. He does a genius effort daily in teaching us all something we should know about our bodies, how to take better care of it, how to reduce our risk of problems going on, how to understand what we are made of. I mean, it's amazing to learn about your body, how it works, how to take care of it, how it functions to its optimal ability, and not just some, bag of bones and fluids walking around. You have an amazing intelligence inside of you that is miraculous and is designed to keep you living your best life. And you do that when you take the best care of yourself. And you do that when you know how your body works. Hopefully that's what Dr. Centeno and I are doing here each and every week with you. We will be here this Friday. We will be here, but notice, make down on your schedules, we will be off next Monday. Dr. Centeno will be in meetings. Next Friday, I will be traveling on the road. So please make it a point to join us this Friday on the Regenix page. We'll be off next week. Until this Friday, on behalf of Dr. Centeno, I'm Dr. Jason Deitch. Thank you for watching. Stay well, be kind, invite a friend. We'll see you next week. Thank you so much for watching.